What's up, y'all, and welcome back to my channel. I am Nurse Lopez, and in this video we will be talking about dialysis nursing, and I'm trying to help you figure out if dialysis is for you. So you will see me looking down just a little bit. I have some notes and stuff that I want to talk about in this video, and I also apologize ahead of time for my dog because I just know that he's not going to make this video easy for me. Let's start off by saying I'm pretty sure most of you know what dialysis is if you're in nursing school, if you have made it to that point. But this mostly for the people who don't know or the people who need like a refresher. Dialysis is for patients with basically kidneys that don't work, simply put. So you know that they either have chronic kidney disease or they have acute kidney injury, which is the reversible kind, and then chronic kidney disease is not. So some of my patients that I work with are acute kidney injury patients, and then some of them are chronic. So some of them urinate, some of them don't. And some of them are new, and some of them have been doing dialysis and kidney support treatments and stuff for like a while. So there are a lot of different modalities like for kidney patients that to help them live longer. Some are kidney transplants, peritoneal dialysis, hemodialysis, which I do, and it's a few other things, but that's mostly for patients who are worse off. So dialysis specifically, though, for the people who don't know, it helps kidney patients get rid of the stuff in their body that the kidneys usually do. So you know the kidneys, for one, they help make red blood cells. Second, the main factor of it helps get rid of the harmful waste products through the kidneys through urine. So like the uric acid, bun, and creatinine is what you learn in nursing school, but in like the actual field, like with me working and stuff, we mainly focus on bun and creatinine. So also with dialysis that we do for them, like the artificial version of their kidneys, we either clean their blood by getting rid of the harmful waste products, or we just remove fluid. And sometimes we do both, depending on the patient and if we could take fluid off or not. So other like things about the patients that I deal with are a lot of them have AFib telemetry monitors when they come in. Some of them have a lot of pitting edema. We deal with a lot of pitting edema. Crackles in the lungs, COPD patients when we look at their like other comorbidities, and I think that's the main things that I see. So as I have said, I am an acute dialysis nurse. So the reason why I specify acute is because it is two different kinds. It's the acute and then it is chronic. So acute, for which I am, it is for patients who are admitted into the hospital. And then chronic is the actual outpatient facilities that patients go on a steady basis. So I get the patients who are admitted into the hospital for other like medical reasons. So maybe they're getting their leg amputated off, or they just got really, really sick and now they need their treatments, but they're in the hospital, so they can't go to the outpatient. I get them. And then chronic just gets the patients who come on a steady like Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday days. So where I work at, the hospital that I work for, I don't specifically work for the hospital. I work in the hospital for DaVita. And I guess it's like a contract or something they have. But also in the hospital, they have another floor that has the outpatient DaVita center. So patients, I guess if they live close to the hospital, then they can just get picked up or drive to the hospital and get their treatments on an outpatient basis. And then we get them when they come in. So like I said, they come in for anything for the most part. Some patients may get admitted and not have no kidney problems, or maybe was waiting until it got really, really bad, and then they end up putting in an access port for them to start doing dialysis, and now they're considered a new start. And also about like the type of patients that I work with, I have worked with a few patients who actually used to do their own dialysis. And it's actually really crazy because you gotta really be a certain type of person to do your own dialysis, especially with the patient having the fistula or the graft and them having to stick themselves to do their actual treatment at home. Like, you gotta really be that person to do that. I've also had a patient who used to do their own peritoneal dialysis at home, but it got infected, so now they're doing like treatments at the actual facility. So as I said, patients usually run 3 times a week, but in the acute setting, they can run anywhere from 1 to 5 days or 6 days a week, because we're open mostly Monday through Saturday and only like stat patients on Sunday. But what I've been seeing lately is the on-call nurse on Sunday actually have been coming in just for regular shifts, because if a patient goes and get an MRI or anything that involves dye, you know that the kidneys is what helps clear out the dye out the system. But now that they don't have kidneys, we wait to do their treatment until after they have that diagnostic procedure so we can get rid of it for them. So yeah, so we have been working, or I have not been, but other nurses have been working on Sundays. So it just depends. But some patients, it just depends on how bad their labs are, or if their nephrologists feel like they need dialysis that day. So the other part to dialysis is we have an acute room, and then we also do patients bedside. So the patients that we do bedside are mostly patients who are on high flow oxygen machines, isolation patients, COVID patients, or in any ICU patients we do in the room. We very seldom do some ICU patients in our room, as long as they're not isolation patients, or if they just got moved there and for some reason, I don't know, we could just do them in the room. But at first, when I first started my orientation and stuff, I was mostly in the acute room, but I have been doing more bedside patients. And when you do bedsides, you're mainly doing that one person for however long that treatment is, and you may only do 2 or 3 patients a day. Because if the patient's treatment run anywhere from like 2 hours to 4 hours, so you got one patient 4 hours, and then the next patient is another 4 hours, that's 8 hours already just for 2 patients. So in the acute room, we have 5 rooms in there for the patients to go. And usually what they do during treatment is watch TV. Some of them play their music out loud and sing and stuff. Some of them cry the whole treatment because they can't stand dialysis. And then most of them just sleep. So it just kind of depends on your facility or your company and what they say that the ratio for a patient to nurse is. But we usually do anywhere from 3 to 4 to 1 nurse, depending on if we have another nurse or PCT, because as I've said, we get all different types of patients from all different types of units, and like anything can happen at any moment, because obviously they're in the hospital for something, so they are like a higher acuity than probably just a regular med surg floor. So it just depends on who we have at that time to actually run their treatments and who the patient is. So I am going to kind of tell you a little bit more from start to finish for my day when I go into work. Starting with, usually we'll get an email, I think, sent out the night before, but I usually don't read it until the day before when I wake up. And it'll tell you if you're low census and don't have to come in till later if they need you. And it'll send a list of the patients who are running that day, so you can kind of be prepared for who you're running and how long your treatment is going to be. So also with that, it tells you everything that you need to know about the patient, like the birthday, the Hep B status, if they're isolation, if they are a COVID patient, and so forth and so on. So along with that same email, they send out a task list that we have to do every morning. Half of it is done by one nurse and half of it is done by another nurse, or maybe by the PCT, but you got to check the emergency equipment. So the oxygen, the suction machines, make sure that we have an oxygen tank in the room, check the crash cart and the expiration dates, check the blanket warmer temperature to make sure that it's not too hot or hotter than what the temperature is actually supposed to be. And then somebody has to come in, which is usually the PCT, and start up all of the machines and start them running and string the machines and everything, like, to get the day started. So usually that's what you do first. And some days the PCTs aren't working, so it is 2 nurses in the room, but there's also times where it's only 1 nurse in the room, and it just kind of depends on how many patients they feel like they can do by themselves. So I am kind of the newer nurse of the group, and then my preceptor was a year, like he had just turned a year probably a few weeks ago. So he's kind of newer as well, so he doesn't usually do that many patients at once, maybe 3 at the most. Which is probably how many that I would probably do. But yeah, it just depends. So after you do like the checklist and stuff, depending on if you're bedside, you just go do your bedside treatment and you connect the machines and everything how you're supposed to. And I won't go too much depth into that because like it's kind of the same as what you do in the acute room, but you set it up connected to the sink in the room to use that water. So in the room, we'll like call them down and have to transport people, bring them down. And the next thing is we do the assessment. The PCTs basically do everything that we can do, except there are certain meds that they can't give. Like I know for sure that they can give heparin off the top of my head, but I don't think that they can give albumin. They can't give blood, and that type of stuff. And they can string the machines, they can check all of the chlorine levels, the bleach levels, because we have to bleach the machines once a week, and we got to make sure that it's gone before the patients are hooked up to it, so like no reactions or anything will happen. So yeah, and then us as nurses, we do the evaluation of care, we do the assessment, and the PCTs usually tell us if they're like blood pressure is really low, and we tell them what to do. We tell them to give them fluids, maybe if that's what is needed, or they usually know to just turn the UF off to stop pulling fluids so the blood pressure can go back up. So yeah, as I said, we start off with basically the assessments, and then we access the ports next. So the different type of ports that dialysis patients have are usually a CVC, which can be either like an IJ in their neck. It could be a subclavian, which is usually like right here, I think on either side, but it may just be on this side of the patient. But it's other places that can have it, like if you look it up. Some patients also have the femoral, where it's near the groin area, and then I think I saw a picture where it can be in their arm, and a few other places that I've never seen before yet. And then they also have, so those are the CVC ports, which are actually the easiest to access because all you have to do is like unclamp it, pull some blood out, flush it to make sure it has like good range, like you can push and pull on it without any problems, check the patency of it. And then the next one is the fistula and the graft, which you'll probably learn in nursing school, or you probably will end up learning when you get to the kidney portion of your nursing school. So the fistula is the best thing for them to have. It has the lowest risk of mortality rates and the lowest risk of infection, and it's where it uses no artificial material in their arm. It just connects the vein and the artery, and that's what it does. And you just basically stick it with the needles and use that and connect that to the machine. And then the graft uses a artificial, like not rubber, but something goes in there to connect the whatever that it is needs to be connected, but it's artificial piece in the arm, which can be infected. But that is the second best, and then CVC ports are the least favorite, but they are the easiest. So I love the CVC ports, even though I know that they are the highest risk for infections, because like it's a hit or a miss. Like you either get a good fistula or a graft or you don't, and it's either easy to access or it's not, which then can cause a lot of problems for you, especially as a new nurse and somebody who is new to cannulating. Sometimes it is really hard. Then after we start the treatments and we get through, like I said, they either get fluid taken off along with getting the harmful products cleaned out, or they just get the fluid taken off, or they just get the blood cleaned. So after all of that is done, we then reassess them, and then we give our reports to the primary nurses. We are not the primary nurses. We are just the dialysis nurses. So anything that we need, like pain medication or any other medications like for blood pressure that to help it increase that they may have an order for, we call the primary nurse for. And then usually they'll tell us where to send them next if they need to go to like observation maybe, or the tele floor, or anywhere else that they need to go, otherwise their room. During treatments, a lot of things can happen though. Mostly what I've ran into, or mostly in what any dialysis nurse probably deals with, are drops in blood pressure. Hypotension is very common in a lot of patients, and usually it could be that maybe they don't have the fluid on them, or their body just does not adjust well to the body being, or the fluid being pulled off as fast as it is. Hypotension is number one. Clotting is another one. I know in nursing school, before I started, I had thought that all patients would get heparin. Like, I felt like that was kind of how it was put in nursing school. But in like real dialysis, or specifically my facility, not many people get heparin. Only certain people. And then once you find out that they do clot after they start, then they may change their order to include heparin. But it is not like a routine thing for everybody. But those are mainly like the two things that are the most common in patients. And then cramps are also common, which is due to like the fluid, maybe not enough in the body. And some people have chest pain, but I haven't really had that many people like that. I've only had like 2 people, and it was only because the blood flow rate was too high, so they ended up changing it in the order that the nephrologist did, and we didn't have no more problems with it. So some of the general nursing like requirements as a dialysis nurse, we don't do everything like that a regular med-surg floor does, of course, but we give blood. Like I said, we give albumin, we give heparin, we do minimal bedside care as an acute center, but I would assume that it would be a lot less, if not any, with chronic dialysis nursing. But I'm only assuming, so like don't take my word on it and then like you go apply and then you get to the job and you doing it, because that's not what I'm saying. I'm just saying that I feel like this job would be probably a good start for somebody who does not want to do bedside care. And you'll be surprised, there's a lot of people in nursing school who don't want to do that, and that is very much okay. So dialysis may be a good choice for you. We do lab draws. We give normal saline when like the blood pressure is really low and it's not going back up. And their blood pressure is staying below 90s. And we also sometimes give antibiotics, but most other medications the primary nurse has to come down and give theirself. So some of the things that we ask about, or that we feel like are important before the treatment that we usually ask about, are if they have any isolation precautions. We make sure to look up their lab values to make sure that if we need to tell the nephrologist about something, maybe in the order that we feel like is wrong. So maybe like the acid level needs to be changed because their potassium is low, so it needs to be increased. Or if it's too high, then we need to have them decrease it to bring the level down. We look at the labs. We look at a lot now. We look at their COVID status, which would basically go along with the isolation. And we would ask about, I guess, how long ago that was taken, even though you should probably, if you're working as a nurse, just if there have ever been COVID while they've been in the hospital, just wear your N95. Like, that's the easiest way to prevent you from getting it. And we look at the reason why they're in the hospital and their order. So, do I regret starting off in dialysis, which is known as a specialty? I don't regret it. A lot of people will tell you, maybe if you talk to dialysis nurses before you start or when you're looking at it, a lot of them will say you either love it or you hate it. and I right now don't hate it. So I guess I would probably stick with dialysis until I realize I do, or until I realize that I'm just like, I'm fine with doing it. Because right now everything is getting to a point to where it's muscle memory, so I don't necessarily care. But I really love my patients, and that's probably the best part of my job. Even on the days when I don't want to work, as I said in a past video, my patients are the reason why like I love working. And when I get in, if I'm like really tired or something, like I just wake up, it's because of them. But that is the main stuff with my job. As I've told you, we do on-call shifts, but not every place does on-call shifts. Like chronic doesn't, but acute does. And it also kind of just depends on the facility and the state that you're in. So I would definitely just ask like the right questions when you're first getting or looking into dialysis, to make sure that it is the job for you. But I kind of have laid out like everything during treatment or the process of my day that y'all need to know. Oh, and also just a little bit about my company. You don't need a BSN to work for dialysis and for the specialty or for DaVita in general. And they have a lot of opportunities for you to move up in the company really quick. Like some people are PCTs and now they are a part of the administration. And you can be a CC, which is technically like a med-surg charge nurse, and then the HSA, which is the nurse manager. And you don't have to be there for like a long time. Like I would prefer you like work as a regular nurse to kind of see the ins and out of everything before you try to move up. But you can move up quick. Like it's not a rule that says you have to wait a year before you do it. But yeah, I think I told y'all about everything that I felt like was important about my job that y'all needed to know. If y'all have any other questions that I may have left out, don't forget to comment, or my Instagram will be at the end of this video. So if you have any other questions that I may be able to answer, you can DM me on there also. But I hope you like this video. I've really been putting off this, but I felt like, especially with me just passing my test that I needed to take for my job, I just needed to do it while everything was like fresh on my mind. But I really hope that this video helped you and helped you figure out if dialysis is an application that you want to fill out, so you don't have to waste your time. But I would definitely say, if you don't have a specific specialty or floor that you're looking into starting on when you get out of nursing school, I would definitely try dialysis, because it doesn't hurt like to try it and see if you don't like it or if you like it, and then move on to the next, which is what I did. I didn't have a specific specialty that I wanted or floor that I wanted to work on, so why not? But yeah, don't forget to like, share, and subscribe to my channel if you like my videos, and I will definitely be back with another video. So yeah, thank y'all. I will see y'all next time.